Good morning, everyone. Just a quick reminder, we'll be starting soon, but a quick reminder, if you are registered for CME, we need you to verify your attendance by putting your first and last name into the chat window so we can assure our continuing education office that you were here. So thank you. Good morning, everyone. Welcome to our fifth episode of Let's Talk About OMM Research. We're glad to have you all here for this webinar, educational webinar presented by Dr. Judith Baumhauer. And just a couple, I'm going to stop sharing here. A couple of housekeeping things. Just if you signed up for CME, please put your first and last name in the chat box so that we can verify that you attended. And there, so during the presentation, if you would use the chat box, if you have any technical problems, because that goes to the panelists. If you have any questions come up during the presentation, if you would please use the Q&A so that everyone can see your questions, we would appreciate that. And finally, we will be having a discussion at the end of the presentation for questions, comments, things like that. So if you will raise your hand during that time, we will unmute you so that you can ask a question or make your comments or whatever. We do ask that when you do that, that you please give a brief introduction of yourself so that we can all get to know each other a little better. Also, if you're making comments, we ask you to, at least for the first round, try to keep it brief so that we can make sure that everyone has a chance to ask questions or make comments or things like that. So, so without further ado, I would like to introduce to you Dr. Judith Baumhauer. She is the Associate Chair of Academic Affairs and a professor at the Department of Orthopedics at the University of Rochester. I met Judy, or I have at least seen her present previously at Promise Health Organization meetings for multiple years now. And she currently sits on the board of directors of the Promise Health Organization. She's published over 100 peer-reviewed papers and book chapters, and her research interests focus on clinical translation of patient-reported outcomes. And so she has used this interest and skill to design and implement clinical trials to bring new clinically important orthopedic products through the FDA into the hands of physicians to improve and advance patient care. We're grateful to have her join us today to talk to us about using patient-reported outcomes in clinical practice. So I will now turn over the time to Dr. Baumhauer.
Thanks, Jane. I appreciate it, and thank you for inviting me to give this talk. I'm going to share my screen for you. Hopefully everyone sees the screen. That's key. First, I want to tell you, I'm a clinician. I'm an orthopedic surgeon. I'm in practice. I'm seeing patients. I always say I'm in the trenches. I do surgery, and yet I saw the value of asking the patients from their own mouths to tell me how they're feeling and functioning, and that's really where the beginnings of this journey has taken me. So let me share a little bit about that with you. These are the disclosures. I really have no disclosure. Jane mentioned that I sit on the Promise Health Organization board, and which is a non-financial disclosure for you. So let me give you as I call it, the dessert before the meal. I wholeheartedly believe that the patient is king or queen, and that utilizing patient-reported outcomes or patient-generated data is really critical as we move forward towards preventative health strategies, maximizing healthy behaviors in our patients, assessing how our treatments are going with our patients and responses to those treatments, and through all of that, allocating healthcare resources appropriately. And I'll tell you a little bit of how University of Rochester has been moving in that direction for the last almost 6 years. People always ask me, what is the difference between a patient-reported outcome and some other type of outcome? Well, a patient-reported outcome is a health outcome that's directly reported by the patient who experiences it and recorded into the electronic record. We're all very familiar with taking some history, and then we might even have a scribe with us, or we'll listen to the patient, and then we'll later dictate what they told us or what we thought we heard, the old grapevine game. But actually, a patient-reported outcome is something that the patient answers directly, and it is imported into the electronic record. So I'm not interpreting it as the doctor, not the nurse, not the tech, the patient. Here's my very best example of this. In 2008, there was an article that was published looking at 3 goals and concerns in regards to breast cancer, asking the patient and the breast cancer surgeon these 3 questions. First question was, how important was it to keep your breast? Well, 7% of the patients thought it was important to keep the breast, and yet 71% of the providers thought it was important. Obviously, we should center ourselves around what the patient finds important. What about live as long as possible? 59% of patients felt it was important to live as long as possible, but they recognized that quality of life is perhaps more important than quantity of life. And yet the providers, 96% said, let's keep them alive as long as possible. You see that disconnect, and that disconnect is where the problems lie. That's why patient-reported outcomes or keeping the patient front and center is the most important aspect, because the patient is the king or queen. As we often say here at the University of Rochester, if you want to know how your patients are doing, you need to just ask them.
Hi, how are you?
Hi, good. 1 o'clock?
What's your last name
Smith,
and your date of birth?
1176.
And who are you seeing today?
Minton.
And any changes to address, phone numbers?
No, it's all the same.
Still Blue Shield for insurance?
Yes.
And are you familiar with the health assessment on the iPad?
I'm not.
Okay. This is an assessment that your provider would like you to take. It's going to ask some questions about your overall health as well as what's bringing you in today. So just read through the welcome screen and tap on begin, and then it's going to be uploaded right into your chart, okay? So you're all set.
Okay, thank you.
You're welcome.
That's how we formulate our check-in. And then the patient, ultimately completes those patient-reported outcomes, and I'll talk a little bit more about that in just a second. And we see the patient in the clinic space, into the clinic room. And of course, I ask about their history. I examine them. I'll look at whatever labs or x-rays or tests that are appropriate for them, and then formulate a diagnosis and treatment. And then I'll make sure I'm on the same page. So that iPad that you previously filled out gives me a little bit of information about you. I can learn a little bit more about how you're handling the care that you're getting, and how your physical function's doing, and how you are doing with pain. So let me show you what you told me.
Okay.
So as I click this button in Outcomes, here is your outcomes information, and it tells me that you're functioning a little bit better, and that your pain is getting better, and that you're able to deal with your injury quite well.
Great.
Yeah. We're moving in the right direction.
Feeling good.
That's perfect. That type of assessment allows me to double check that what I heard is how they're feeling and functioning. And then we've been able to do some additional assessments research-wise with the data to see how it might be valuable in making some treatment decisions. Well, people always ask me, how did you decide what you're going to gather from a standpoint of patient-reported outcomes? Well, we had some must-haves. It had to be a validated instrument, of course. It had to be quick. We always say not on the backs of the clinician, meaning that we can't hold up our office to throughput to have somebody fill out something that's long and laborious. We see 17,000 patient visits a month in orthopedics here at the U of R through one of our buildings. And that's an amazing throughput. It can't be costly. It needs to be generalizable and flexible, because if you're seeing somebody with upper extremity problems or lower extremity problems, or even I would tell you cancer or pulmonary disease or urinary incontinence, you need to be able to collect data that might be important to all of those aspects. It needs to be viewed in the electronic record, and it needs to be searchable for research purposes. We sort of landed on Promise, and I'll tell you a little bit more about Promise in just 1 minute. But the platform that you saw with that QR reader code was actually quite novel about 6 years ago, and now people have incorporated it for use since we've started to expand and talk about this. Our platform we call the UR Voice, a cute acronym for Validated Outcomes in Clinical Experience. We initially had a mantra. We say every patient, every clinic, every visit. And then we realized, that's not fair, because sometimes the patient doesn't need to complete it because it's not going to be necessary for decision-making, as we got a feel for the data. So now we have these delivery windows, and we like to say we ask PROs at the right time when it matters the most. Well, what is Promise? And many of you might know about what Promise is, but it also is an acronym for Patient-Reported Outcome Measurement Information System. It is an 11-year, $100 million effort by the NIH to assess symptom-based complexes in patient-reported outcome initiative. So what makes it novel is it's domain-specific, meaning it asks about symptoms, like how you're functioning physically, how much pain you're having, your depression symptoms, your anxiety symptoms, those sorts of things, and not disease specific. It's not asking about knee arthritis or hip arthritis. And that's what made it different, and that's what made it generalizable. It's also standardized across these different domains or symptom complexes using T-scores. So as we all know, a mean of 50 with a T-score was the mean for US population, is how they standardized this, and 10 points is a standard deviation, whether it be more or less. It allows us to follow patients throughout a healthcare system through different medical conditions. And you can produce this data quite quickly with these computer adaptive technology and item response theory, smart testing as we call it. Here's just the 3 buckets of promise domains. One is physical health, one is mental health, and one is social health. This is a very small smattering. There are hundreds of different symptom complexes. It utilizes sort of the biopsychosocial theory that was actually originated at the U of R. So it's sort of our legacy. So it was natural for us to gravitate towards promise. So in orthopedics, when we started this in 2015, we collected physical function, pain interference, how pain interferes with your life, and depression symptoms, which we like to call mood. And as we began collecting and recognizing that using the smart testing, it took us about a minute per domain, it was pretty darn quick. And other departments and divisions were interested in beginning to collect this as well. Our first big partner was cancer. They said those 3 core domains were good, but anxiety is important. So we, as we call it, added anxiety into their promise package, if you will. Then palliative care. They said fatigue is a good indicator of end of life. So they wanted to follow fatigue. So they followed fatigue. The urinary incontinence is important with the urology guys. So they said the ability to participate in social roles and activities was really important for them. So we collected that for them. You can see how this could spread across a healthcare system. You could get some core domains, if you will, for population health management. And then you could use focused ones around what the patient finds important or the provider is tracking in order to follow patients' treatments. People always ask us, why did you get depression? You're an orthopedic surgeon. You guys don't really follow depression too much. Well, we recognize how someone is feeling impacts how they will participate in their care, you know, how they'll deal with surgery, how they'll utilize physical therapy afterwards. And here's one of the early articles that came out saying mental health has a stronger association with patient-reported shoulder pain than the size of the rotator cuff tear. So we recognize that depression or the integration of that mental health component is really important for us. This is just a snapshot up till December of this past year, talking about our collections. We had almost 275,000 unique patients since we started in February 2015, and over 3 million scores. In the center aspect, you can see that most of them are promise scores. Promise has pediatric domains. It also has parent proxy domains. So it really did transcend our ability to collect across large populations. But we're also increasing our number of non-promise scores that you can see down here. And I'll talk a little bit about that at the end. It takes about 44 seconds per domain. And if the patient gets the iPad, then they usually go ahead and complete it. If they're not given the iPad, that's where we lose caption. Well, is it important to collect this data? Do patients like it that you're monitoring their symptoms? Yes, they do. Patients feel as though it's important to them, for us to understand how they're feeling and functioning. It empowers them, it engages them, it activates them, and it helps them to also be on the same page with you, and they can track the same outcomes from themselves. It also helps us with shared decision.
My name is McCoy. I'm a doctor.
What am I, a doctor or a moon shuttle conductor?
jumped every time a light came on around here. I'd end up talking to myself. I'm a doctor, not a bricklayer.
You're a healer. There's a patient. That's an order.
I'm a surgeon, not a psychiatrist. Look, I'm a doctor, not an escalator. Spock, give me a hand. I'm a doctor, not a mechanic. I'm a doctor, not an engineer.
No, you're an engineer.
I'm a doctor, not a coal miner.
Keep saying that. Are you a doctor, aren't you?
I don't know.
I sort of love that because you know what? I am a doctor down to my core. But understanding how the patients are feeling and functioning is exactly what I want to be doing. I'm going to talk to you a little bit about how we use this data in the clinic, in the trenches, as I say. We are lucky enough to actually be approached by the people at the New England Journal of Medicine for us to write a perspectives article on patient-reported outcomes and are they living up to their potential, and publish that in 2017. I knew we were onto something if the New England Journal was coming to us. It was quite an aha moment for me. This is just a snapshot of what you might see in our electronic record if you opened it up to a patient. This is our outcomes tab at the top. Oops, I'm so sorry. Our outcomes tab at the top. And this is a simple central one, has a little promise. You click on that, and this gives you this graphic display. On the x-axis is time, on the y-axis is t-score. The red is physical function, the green is pain interference, and the blue is depression or mood. We made it so that it was really simple to visualize in a moment. We made it so that down is bad, up is good. We also put on severity bands so that the red is severe symptoms and it goes up to the gradation of green, which is, I always say, good to go. So prior to seeing a patient, they collect, they finish out their patient-reported outcomes or promise data in the waiting room. It takes them, as I said, 2.4 minutes to fill out the 3 domains that we asked about, and then they're roomed. Obviously there's no waiting time really. So if I see this patient, it's the first time I'm seeing this patient, I will start by looking at their baseline values, because I want to know how impaired they are. And I'll do this before I go in to see this patient. If I'm, because I like to get a feel for how much trouble they're in. If they're, approaching the green or doing relatively good, then I'm going to try not to make them spend $1 zillion, such as custom orthotics or custom braceware or something like that. I'll realize maybe an over-the-counter product might be acceptable. Maybe home physical therapy instead of sending them once or twice instead of an 8-week course. But let's say it's a follow-up patient, and here's a this patient's now a follow-up patient. You can see that their scores are all in the green, so they're good to go, and yet they're in my clinic. That to me is an easy patient to see, because I'm going to be able to go in and chit-chat with them and let them go relatively quickly because they've responded to the treatment. But if the points are actually a downward angle, it's going to be a more challenging patient. It'll actually target who I see next in my clinic. If there's 3 people in a room, I'll go see this easy one so that they can come out and the next person can be put in, so I can spend that overlapping time in with the more challenging patient. We also get a patient-reported outcome that's called a PASS score, a patient acceptable symptom state. I always say, can you live with what you have? And we do that because I want to know not only their severity of their problem with the promise scores, but how they feel about their symptoms. Are these symptoms that they can live with? So here I'm going to walk you through this. I keep showing the same graph for ease of use here. This is a patient I saw that was diagnosed with ankle arthritis. Initially, I'm going to try some non-operative things, including non-steroidals, an ankle brace, maybe some rocker-soled shoes. And then I'm going to see him back. Now I'll have a conversation with the patient. I'll tell them actually all the options. And believe it or not, they always pick the non-operative things first, appropriately so. So now I see them back, a couple months later, and they said, you know what, it's not working. I looked at my promise scores, and you know what, it's not working. So they're not doing any better with these non-operative treatments. So we start to talk a little bit more detail about surgical intervention. They choose for surgery, and then I operate on them, and I fuse their ankle. Well, you can see their physical function is severely impaired because they're in a cast on a pair of crutches. But guess what? They don't have any pain whatsoever because they're in a cast and on crutches. And their mood's pretty high because they made it through their surgery and they're on the other side of this. So you can almost explain these how these graphs go. And they should follow a certain pattern. As you see these patients, you realize these patterns, we call it a check mark pattern, where they go down and come back up again. Now I put her into a walking cast, and then I get her out of her cast and into physical therapy, and now she's doing quite well. Well, with this type of sort of course, I can show the next ankle fusion patient how they're more than likely going to behave through a course of treatment. So you can use this as aggregate data too. Well, let's look at this pattern. This patient came in, they had a hip replacement. And then as they're being followed yearly, essentially, they've declined. Well, do you expect them to decline in 2 years? No, you sort of think they're going to be flatlined, where they're going to stay in the green. Is this representing maybe there's something wrong with the hip? Maybe they need to be looked into a little bit more significantly, or at least have a conversation with them. You don't know it's related definitively to the hip. That's why our conversations need to focus the patient. I noticed from your promise scores that you're having some limitations with your physical function. Is this related to your hip? And you know what? They may say, no, my hip's doing great. The other hip's bothering me now. So it helps us target these things. Now with this aggregate data, here's a patient that says, you know what, I have a bad knee and I want to be more physically active. Will surgery allow me to do that? And yet their T-score is 47. Remember, 50 is the US norm. So they're a little impaired. They're in the mild impairment. Well, we looked at an aggregate data collection of 118 total knee replacement patients. And we recognized that if your physical function is better than 44.5, you had an 88% probability of failing to meet any clinical important difference. So they fell in this red frowny face area. Well, what does that mean to the patient? The conversation back to the patient is this. You say, yeah, I noticed that you're having some limitations in your physical function, but actually the surgery doesn't make someone like you better at this level. We should talk about other options, like maybe we need to do physical therapy, maybe we need a cortisone injection, maybe we need to change your activities from running to biking, conversations like that. Because surgery is not going to make this person better, and they'll just be disappointed with it. There are several different procedures to treat my problem. How do I choose the best one? Well, in concert with the surgeon, they might have gotten a second opinion saying, this one person told me to use this tendon transfer, and the other person said, just use my own tissues and just do a tummy tuck, as I call it. So here's 3 different surgical procedures for ankle instability, ongoingly rolling your ankles. And look, as you follow these patients along for physical function and promise physical functions on the y-axis and time is on the x-axis, you can see they sort of stratified, recognizing that one of these outcomes is actually better than the others. Then you recommend to the patient, see, we've looked at this and we recognize that this treatment works better. Or even more importantly, we go back to the surgeons and we say, look, we've taken your data, we've run these analyses. Here's these 3 different types of surgical procedures, and there's variation in outcomes. And guess what? There's variation in cost too. So we start to look at value. There's different surgeons. Who's the surgeon that's best for my type of procedure? We took 6 of our sports medicine surgeons that did ACL reconstructions for knees, and we graphed them for physical function. And guess what? Their outcomes were relatively similar, but their costs weren't. And we started to drill into the costs and recognized that one of the surgeons or 2 of the surgeons had lower costs than the others. And they started to align their costs so that we could define value. What about a trajectory? I talked a little tiny bit about you had an ankle fusion. You can sort of see the trajectory of that ankle fusion as we walk through the PROMIS scores. Patients want to know things like, well, I'm going to have this surgery. When is it that I'm going to be able to go up and down stairs? Because my washer's in the basement, and I want to know when I'm going to be able to accomplish that. Well, you can actually stratify by snapshots, different activities. And climbing stairs is one of these activities. And I know this is a little hard to see, but down here it talks about going up and down stairs at a normal pace. So you drop a line over to that green and look at your T-score over on the y-axis, and you realize that really a T-score around 42 will allow a patient to be able to go up and down stairs. Well, how does that translate back to our patient that has ankle arthritis? Well, it's going to be a T-score that falls essentially a time frame through their recovery time. And so you say it's going to be about 10 weeks till you're going to feel up to going up and down stairs easily. It's really great to be able to tell patients what those answers to those questions with a little bit more confidence than the way that we used to, which was sort of guesstimate. I would tell you patient-reported outcomes have to be defined with the patient in the conversation. So you might say, for instance, this patient who has a bunion, it hurts over the prominence of the medial eminence of their great toe is inclined, they're having troubles with shoes, closed shoes, but sandals are fine. Here is their graphic display. You can see when they came in, they're doing pretty darn well. They're in the green. You'd say, well, don't operate on them because you're not going to make them any better. Well, what is it that the patient wants? They say, I want to have my toes straighter so I can fit into shoes. Physical function isn't the marker that we use to track these patients, because if they wear sandals, their physical function is absolutely fine. So you have to ask the patient, what is it they're hoping to get out of this treatment? And then target your domain that you're tracking to meet the patient's needs. How did I know that that patient wasn't doing well enough to skip doing an operation? Because I asked their PASS score. I said, can you live with what you have? Your PROMIS scores show me you can. He said, no, I can't. So there's a disconnect between her PROMIS scores and her PASS scores. And then it gives me the impetus to ask them, what is it that's holding you back? What are you hoping that we're going to be able to help you with to make this successful or satisfactory? So it comes down to, patients like you who have these types of initial baseline scores tend to do better with this form of treatment. And it allows us to engage our patients in shared decision-making. Now, we also do some predictive modeling, and I won't go into all of this, but there's a lot of different ways that we've used other predictive modeling beyond what I've shared with you. And it's been really exciting. It's been exciting to patients and exciting to us. It has helped us advance PROs in clinical practice and unite our healthcare system. So in summary, as I began, I said the patient is king or queen, and that patient-generated outcomes and patient-reported outcomes, and visualizing them, discussing them with your patient, and utilizing them are really helping us with preventative health strategies, maximizing healthy behavior, assessing our treatment responses to these variety of treatments that are sometimes quite costly, and allocating our healthcare resources in the right directions. So I have a number of references that I have provided And I thank you again for this opportunity. I'll stop sharing now. And if there are any questions, I'm happy to answer them.
Thank you so much. I learned something new from you every time I hear you speak, so I appreciate that. So we do have one question in the Q&A box. That's when you say validated instrument, to what type of validity are you referring? Who adjudicates that it is validated?
Yeah, so a validated outcome, you're right. There's many different, there's content validity, there's construct validity, there's, you have to responsiveness to change. There's a lot of different things. In this particular case, when I used promise, it was, as I said, 10 years, $100 million. It was constructed with psychometricians, and its validity has been published on. I would tell you that if you're thinking of using a different outcome instrument, which I think there's many out there that are valid, make sure that you do a literature search and you get up the validation of that instrument and confirm to yourself and those who are going to be with you that it is in fact valid. So, in the old days, when I started looking at patient-reported outcomes, really was in the 90s, and there were tons of instruments that were called valid, but the validity was never really established. So you need to make sure that there's published validity on an instrument before you use it, especially with your research, but also, of course, with your clinical care. I see the other question is, well, what type of EMR infrastructure do you need? Well, there's a lot of different ways to collect patient-reported outcomes data. One of my friends, Jeff Hauk, is a PhD, and he works in Oregon, had worked in Oregon, and he's coming back to the Rochester area. But anyway, he's in Oregon, and there's a website called healthmeasures.net that has a link as one of their website pages on how to collect PROs. They have a web app that you can use on your phone, on one tablet or something like that you can purchase. Ours was a custom made platform because at the time there was nothing that was collecting like us. Now the healthmeasures.net would be able to guide you. All right, so Dr. Brooks, thanks for the nice comments. We feel really good about what we're doing. And, the other thing is we're not stagnant. You start out and you say to yourself, you spend, months figuring out what instrument should I use? What should I collect? I'm really worried, I'll be stuck with it forever. We don't do that because we're on real time. We just change it. It's if it's not working, we're not continuing it. So don't be paralyzed by selection. I have plans for long-term follow-up because it's being collected across my healthcare system. I forgot my classic line, which is my internist is collecting my follow-up data, because the patient I might have operated on, say that ankle fusion, that I'm not seeing back anymore because they did great, right? Why would I see them? They're in the green. Why should they pay a copay to me? That's just rude. So I look at their data. If I wanted their data and I was doing a research project or something, I can pull up their data and it'll be updated by the internist because they've gone to see the internist, or they've gone to see, they had cancer and they're in the cancer world now. So my data can be updated by that. Let's see. As I said, it's not, I guess that was the question about it's not affordable if you're not part of a healthcare system. It is affordable because you could use an app. The app is really affordable. I would really refer you over to the healthmeasures.net. It's kind of cheap to do it that way. The other, Red Cap and stuff like that is available too, but you don't get to see it in real time. So I like the app. Is the Promise system a program that one would purchase? No, well, there's an API. I forget what API stands for, but basically it's a leasing program that you can purchase for. I want to say it's $7,000 a year, but as we have 3 million data points, so we're getting good value out of ours. If you're not going to be that number of patients or something, just get the app. The app's I think it's $500 a year or something really somewhat affordable. I also feel like perhaps this, but MIPS, some of the incentivized payment programs are going to require patient-reported outcomes. So right now we're talking about it sort of in research and stuff, but ultimately it's going to be for care. You're going to have to justify why your care is what it is, and you're going to have to track something. So you have to start to get familiar with which instruments are going to be right for your patients, what are important to the patients, and make sure you're monitoring that. Let's see, I'm assuming that each procedure has a tailored Promise score, or do you cast a wide net and use CATs to narrow down the questions being asked of the patient? So the CAT tools uses item response theory. So usually, like in the physical function domain, there's like, I want to say 150 questions. And of those 150 questions, 4 questions or up to 7 questions would be asked. And then they got you pegged, because they'll ask the question, can you run a mile? And if you say, yeah, I can run a mile, it's not going to go back and say, can you walk room to room in the house, or one of those things. So there's a litany of questions, 150 questions, and you get targeted by narrowing it down. That's what item response theory is. That's why it's so quick to answer that. I should tell you that Promise also has short forms, and they're free. Maybe I should have said that before. They have short forms and they're free, and they have a Promise Global, which is, they have a 10 question one, which is pretty quick. The 29 question one, which I think a lot of people use, has 7 different domains embedded in it. It is a static questionnaire though, so you're going to answer all 29 of those questions, unlike me, where you're going to ask 4 to 7 questions per domain and leverage the power of 150. With the 29, you'll just answer those 29 questions. But that's a great way to track people too. Jean, I don't see any other questions.
So I think Brian has a question or a comment. If you want to unmute yourself.
Yeah, thank you so much, Judy. Your presentation was perfect for where we're at with our network. Certainly one of the challenges that we face is that transition time and implementation, getting clinicians on board, getting our patients on board with a whole new system, potentially a whole new perceived time drain in the process of getting patients back and so forth. Could you give us any insights on how that was managed, and was it a challenging transition, or was it really quite simple?
I think once you understand a workflow, then you realize it's pretty simple. Literally when that video, the reason I show that video is it's so illustrative of how it goes. It takes that person who took they took the iPad, it was quick, they handed it off, and it takes that patient 2.4 minutes to finish it up. So if you get a workflow like that, it's good. And as I said to you before, we're not static. We're actually changing off, it's scaring me to death, but we're changing off our custom platform to incorporate into Epic. And and I know that there are many other quality questions that are being asked, falls risk questions. There are questions about domestic violence. There are questions. And these are required questions for us as clinicians to answer. So a lot of those questions you could also put onto your tablet and not have to answer them out loud. I trickle when I hear the tech take my patient back to the room, and I can hear them as they're getting their blood pressure taken. They go, now tell me, are you safe at home? Anybody, are you having any trouble with? Who's going to say that out loud? Who could do that? In the falls risk, I joke and say, yep, somebody's, the daughter's coming with the mom to the clinic visit, and the tech asked the mom, have you fallen in the last month, or do you feel at risk to fall? Well, the mom, who's, 88 years old, says, nope, I don't feel at risk to fall, because in her mind, she's like, if I say yes, then my daughter will pull me out of my home and I'll be in some other space that I'm not interested in. So patients don't want to answer those things out loud. They want to be private, and they want them to go immediately into some place, not sit on a piece of paper exposed. So for all those reasons, it's good and good and good. People are familiar with iPads and stuff now. We actually diced up our data quite a bit at the beginning, wondering if older people, it took a little longer, or if they just didn't do it because they got frustrated and stuff. But it wasn't like that. They did take a little bit longer, but they didn't just pack it up. I mean, they're going to the bank and they're taking money out of the ATM, so it's all okay. It works out, but you got to do the workflow, and you got to have everybody at the table. It's just like any program that you do. If you don't have all your stakeholders having their voice heard and having engagement, and you're shoving it down their throats, they're not going to want to do it. So you need to have your staff all on board, because they have to, as my fellow always says, you got to sell it. You got to sell it, and you got to just sell it. Anything you do, you have to sell it. So.
Thank you.
Yep.
I see that Marcus has his hand up.
Yes, he does. So hi, this is Marcus, osteopath from Germany. Thank you very much for this very interesting presentation and those insights into your work. I thought it was very fascinating to see. I got also a little communication question. So you showed us a graph of, I don't know what it was, people having some treatment, and you said you could show this to the patient and say, like, if you have this issue, this will be what's going to happen to you, probably because this happened to other people as well. What I thought was, especially when you see a sudden drop at the beginning right after the treatment, maybe, do you think that there is room for a nocebo effect in this moment? Because it's very important what we communicate with patients who have no medical background, no understanding really of what's happening to them or with them. And I thought maybe this could be, some form or some source of bias for putting people into a nocebo, because they think like, oh, this happened to everybody, so I will feel bad right after this or that treatment happened to me. Does that make sense?
Yeah, no, I got it. I think, that big dip was because I operated on them, so now they're in a cast or on a pair of crutches and they're not doing anything. So that's that big dip. We call it a check mark, because, they come in and then we operate on them. They go in the tank, and then they're like a Rocky theme. They make their way back up. And that's sort of how we describe it to the patients. I don't know. I think patients want to know what they can expect during the course of their recovery, and whether or not telling them that this is how someone else felt is a bad thing. I don't think so. I think getting them to know that this is how it goes. This is the average for things, just like building a house. You say, when I built my house, it's going to take, 8 months. Well, then I have some expectations in mind that I'll be moving in month 9, right? Mm-hmm. I think the same thing for surgeries and for other treatments, because patients sometimes think that you do something for them and they're going to be perfect afterwards. When in actuality, most surgeries are, it claims 10% of normal. So they're going to get back to 90% for the best of surgeries, I think, get you back to 90%. And I think patients having an understanding of that. It's clear you manipulate the patients every day, talking about treatments and set things up. And but I had my mom had some dementia, and they treated her with a pill that I thought, oh, this is never going to work. And my mom said, I think I feel better. And the person, the psychologist or whatever that gave her the medication, I said, you know, she thinks that she feels better with it. He goes, I celebrate the placebo effect. And I thought, I do too. And so to your answer, yes, I might be influencing how they'll be doing, but I also think patients can't memorize those graphs. They remember like 5% of what I share with them. So I think the tracking is good, though. I think sharing with them what they can expect is really important.
Yeah, absolutely. I totally agree. It was just the thought, like what happens if you see like a graph, because we always just work with words, right? We try to picture it with words. And is there a difference if they see something like it's in the red now or something? But it's very interesting to hear your opinion on that. Thank you very much.
You know, you're spot on, because there also was, you know, there's been some PCORI grants that have been done looking at with patient focus groups. How do they want to look at it? You know, I show you information like the smiley face and sad face. I don't show that to patients, right? Mm-hmm. Patients we do struggle with the concept of putting something in the red. It's almost like you know, you're going to have a bomb blow off or something, right? It seems volatile. And I do worry that that's maybe not the right color or whatever, but it is what it is. And the last thing I'll tell you is, one of my really great examples of why this works for me is, in the old days, I used to walk in to see a patient, and I would, and I'd say, hey, how are you feeling today? And they said, I'm doing great. And I said, oh, you know, are you back to work? And they go, oh, no, I'm not back to work. So then all of a sudden I'm doing my item response theory, because it's like, they're not back to work, but they're feeling great. So now I try and stagger myself in with questions, right? But now what I do is I look on my promise score, so I'm on the same page as them. And then I go in and I'm closer to where they actually are. And, you know, that's why patient engagement is better, because there's been multiple studies that say if you go in all happy and the patient is depressed, that disconnect makes that office visit bad. Mm-hmm. Where you go in, you know, somewhat aligned with where they are, then you're in a better place. And I think that has really helped me too.
Sure, that's a good aspect. Thanks.
Another thought that I had is, as you were saying that, was the patient acceptable state, symptom state question would really help with that too. You know, asking them, is how you're doing acceptable to you?
Yep. And, you know, like I said, you know, I actually do foot and ankle. That's my elective practice. And, you know, none of my durable medical goods are paid for, and they're all really expensive. And, you know, patients will do what the doctor says on them for the most part. Many patients will. And if I said, oh, you know what, you know, you have this problem, and you go and, you know, go to the physical therapist for 8 weeks, 2 times a week, and their copay is $50 each time they go. I mean, it's quite a lot of money. And yet they said, I could live with what I have. So maybe that's poor allocation of their money. And, you know, every day I am looking at those things, and I'm deciding in my mind, and then I'm validating that my answer is correct when I have a conversation with the patient. And that's how I make my decision trees. You know, somebody put in here that, you know, I have great empathy. I like to think I do. Thank you. I guess I want to be treated like I would like to be treated this way if it were me in that chair. So that's how I do it, just like everybody else. How much management of individual providers is done by administration based on comparison of providers? I'm not sure exactly what that, who's Jed, and can you speak up? Can you unmute and tell me your question?
Okay, I'm unmuted now. Sorry about that. Okay, so you showed the graph of the cost of the various providers who were performing the same procedure.
Yeah.
And there were changes made, which certainly seems appropriate. But I'm just kind of wondering how much this data is being used by the hospital administration or the healthcare administration system to dictate the behavior of individual providers.
Yeah, so this is the I don't mean to say paranoid question, Jed, but a little bit of big brother looking over what you're doing. We don't have any of that, and I think that it probably could happen in a bigger. We're at the University of Rochester. We're a private institution, university institution, but I would tell you that if you were maybe in Geisinger or one of the bigger health systems, perhaps that could happen. But it's funny, if I wanted to do something as a surgeon, I could get it done. And even if they put up barriers, I could do a workaround. We're smart and we can do that. So, you have to get people aligned along the right, same resources and things like that. So none of it happens to us here is the answer for that. However, I could see how it might be, but it's hard for administrators to be able to critique the data like that.
I think we have one last question, and then we need to finish up. So.
Okay.
Go ahead, Bill.
Oh, okay, you're talking to me. Okay. So I'm the one who asked about long-term follow-up, and you gave a very cogent answer. And you're talking about quality data within your whole system, correct?
Yes.
And how do you then use that for research? We're struggling at the University of Arizona, which interestingly, it's the orthopedic department that's leading that effort. To initiate this kind of data collection. And the model has been prospectively collected and then potentially retrospectively reviewed, nested, IRB approved, de-identified data. And this is in contrast with what Dr. Degenhardt and his group are trying to do with DO-Touch, which is consented data. And there's a cultural difference. I mean, one of the big hits about manipulative medicine, provided whether by chiropractors or osteopaths or now manual medicine by physical therapists, and is that, people feel better for a few days, a few hours, a couple of weeks, but they always got to come back. And it's the long-term response that's so critical in adjudicating a lot of these issues. So I don't have a really specific question, but I thought it was important to point out kind of the tension between these models and the attempt to not only improve patient care, but how we research this. And if you have any thoughts to add at this point.
But I'll share a couple things. One is that the IRB, initially we did them on onesie, twosies. Every project that we came up with, we put it through an IRB. Then the IRB realized they're going to be like stuck with us doing these promise things. And so they gave us, we call it a global IRB. We got underneath the umbrella of the IRB, they said if you collect these data elements, and that includes any of the promise scores, some of the demographic data for the patient, and it's utilizing that information, and there's a couple other things, then you don't have to use an IRB. We have a global IRB number that you can use, and that was a game changer. Secondly, I will tell you that my fellow is graduated from the Mayo. And at the Mayo, you know, when patients check in or whatever, they, along with their signatures of, you know, here's my credit card information or whatever, their intake information, they also sign a thing that says my data may be used for research. And that goes under that global IRB allows them to do a lot of these things too. So I would tell you that those are a couple ways of dealing with this. And the last thing is, I don't know, you know, again, the electronic record is a personal thing, and I don't know what University of Arizona has, but, you know, pushing out data at a year or something like that, the patient reported outcomes is possible through Welcome Mobile, MyChart, those sorts of things through Epic. I'm not an expert in other electronic records, but certainly you can time these things and you can do it through include patient reported outcomes. The collection is what the problem is. The patients aren't motivated to complete that information. Those are all the challenges.
Well, thank you so much for helping us to understand the ways that we can use patient-reported outcomes in the clinic. Not me personally, since I'm a statistician, but but as our network can use that. So we appreciate all of your input and insights. And I will ask everyone to please join us for our next Let's Talk About OMM research session. We have a journal club coming up that is on March 19th. The timing on that day will probably be changing because that's during the American Academy of Osteopathy convocation. And so just to make sure that you know that we may be changing from our usual time on that. And our discussant will be Dr. Bill Brooks. So we're grateful, and thank you again for joining us. And thank you, Judy, for sharing with us. You all stay healthy.